Good afternoon, everyone, and thanks for the opportunity to be here virtually. It's a pleasure to be here talking at ACCC again. We're going to be talking about the recent heart failure guidelines update by the CCS. This is my disclosure slide. To start off, let's talk about an inpatient case. So let's start off with a case, and I'm going to try to paint the picture of a person that comes in with a de novo familial cardiomyopathy who seems relatively stable once we start diuresing them. So we have a 65-year-old male, presents with 3 months history of worsening dyspnea, orthopnea, and PND. Antibiotics did not help. Seen in the emergency department again and admitted with decompensated heart failure. No angina or equivalence to angina. Heart rate's 102, blood pressure's 114 on 78. Setting 98% on 4 liters nasal prong. JVP's 10 centimeters above sternal angle. They have an S3, and they have crackles about a quarter of the way up from the lung bases. They have edema to the mid-shins. Past medical history is type 2 diabetes with an A1C of 9.8% on metformin, 1,000 milligrams POBID, and that's kind of important because we're going to talk about pharmacare coverage for SGLT2 inhibitors later. They do have a family history with a sister and brother both having weak hearts. No history of heart attacks. Admission, so day 0 and 1, they're appropriately diuresed with Lasix 40 milligrams IV BID. They were not started on a beta blocker to try to get them more compensated. On day 2, they've diuresed about 3 kilograms, and you review their echo. Their echocardiogram shows an LV EDD of 6.5 centimeters. Their EF is 20 to 25% with global hypokinesis, mild functional MR. Blood work shows a good creatinine, good kidney function. Surprisingly or not surprisingly, their potassium's down to 3.3 with the diuresis. Their vital signs are stable. Interestingly, their blood pressure is 108 on 68, and their heart rates come down to 90 just with diuresis because they're becoming more compensated. The exam shows a JVP down to 8 centimeters. They're off oxygen now, only scant crackles on exam. The S3 is gone, and the edema is improving. Medications are bisoprolol 1.25 milligrams PO daily that was started the day before by your colleague, spironolactone 25 milligrams PO daily, and you're thinking about starting some other medications. What are we going to do now? So this is what we've written on our day, so we're going to fluid restrict them to 1.5 liters, daily weights, daily lights, creatinine, and urea. We're going to record their ins and outs. Lasix 40 milligrams IV BID at 0800 and 1400. We've given them a small dose of bisoprolol at 1.25 milligrams PO daily and spironolactone 25. So what should we do next? So we're going to cover this from a private coverage perspective and a pharmacare perspective. So let's talk about why we care about what we're going to start next. This is a graph showing mortality risk following heart failure hospitalization. On the y-axis is a hazard ratio, and on the x-axis is time in months. The highest hazard ratio is within the first 0 to 1 months post-discharge, so when someone gets admitted to hospital with heart failure hospitalization, their highest risk of dying is in the first 0 to 1 months. Interestingly, the adverse events mortality risk is twice as high during the first 30 days compared to 6 months after discharge. So we're really focusing on doing everything we can while they're in hospital to try to decrease this hazard ratio risk within the first 0 to 1 months, because we know they're at the highest risk as soon as they're discharged home. Interestingly, in Canada, there's a 25% 1-year mortality after hospitalization. As Dr. Anderson has shown in our recent grand rounds with Nova Scotia specific, there's a 41% 1-year mortality post-hospitalization. So optimization in hospital is imperative. So now we know why it's important to optimize someone as best as possible when they're in hospital. So now what should we do? This is a little snippet from the CCS Heart Failure Guidelines Update 2021. We're going to focus on number 4 and 5 here. So looking at number 4, we recommend that patients admitted to hospital for acute decompensated heart failure with HFrEF should be switched to an ARNI from an ACE inhibitor or ARB when stabilized and before hospital discharge. Strong recommendation, moderate quality evidence. And number 5, we suggest that patients admitted to hospital with a new diagnosis of HFrEF should be treated with an ARNI as first-line therapy as an alternative to either an ACE inhibitor or an ARB. Weak recommendation, moderate quality evidence. The recent updates came from 2 trials and more experience with real-life data. It's hard to believe that Paradigm-HF came out almost 7 years ago. It was a paradigm shift in the way we treat chronic heart failure with reduced ejection fraction. Much like the paradigm shift that is happening in the Marvel universe right now with the Scarlet Witch and Doctor Strange, Paradigm-HF was a paradigm shift as we transition from ACE inhibitors and angiotensin receptor blockers to ARNIs, or angiotensin receptor neprilysin inhibitors, as management for chronic heart failure. This is the Kaplan-Meier curve from Paradigm-HF, which shows the primary endpoint, which is either first hospitalization or death. On the y-axis is cumulative probability of those, and on the x-axis is days since randomization. The curves separate early and continue to separate throughout. It gives an impressive number needed to treat of 21, and an absolute risk reduction that's close to 5%. So this did change the way we practice with chronic heart failure with reduced ejection fraction. So in those stable patients, we switch them from their ACE inhibitors or ARBs to a neprilysin inhibitor. This led to Pioneer-HF, similar to Davy Crockett on the right. In 2018, there was a proof of concept trial to see if angiotensin neprilysin inhibition was okay or safe to start in acute decompensated heart failure. This is a graph showing the primary endpoint from Pioneer-HF. There was about 450 people in each arm, randomized to either enalapril or sacubitril valsartan. On the y-axis you see change in NT-proBNP from baseline, and on the x-axis you see weeks since randomization. In the group that received enalapril, they did have reduction in NT-proBNP, proving that ACE inhibitors work. And in the sacubitril valsartan arm, there was more reduction in NT-proBNP. What does that mean clinically? It's uncertain. But what the other point was to look at secondary endpoints to see if it was safe to initiate in a hospitalized patient. I only want to focus on one thing right here. We'll get to the nuts and bolts of it at the end, but right here in a secondary endpoint analysis, rehospitalization for heart failure was reduced by about 5%, and it was statistically significant. I do want to focus on a couple of baseline characteristics in the group. Right here, particularly the systolic blood pressure. The median systolic blood pressure was 118 millimeters mercury. And if you look at their interquartile ranges, it was between 110 and 133, and those are pretty similar in both groups. So this suggests that the patients that were randomized to getting sacubitril valsartan had good blood pressures, and they were getting better. If you look at their heart rates, the median heart rate in each group was 81 and 80 respectively. So these aren't the people that are decompensated, trying to keep their heart rate up to get better cardiac output. Conclusions that we can safely make from Pioneer-HF. So sacubitril valsartan therapy decreased NT-proBNP concentration compared to enalapril therapy at 4 and 8 weeks, sure, without significantly different rates of medication-related adverse effects. Reduction in rehospitalization was a secondary endpoint. Caveats: good blood pressure, getting better from their decompensation. And interestingly, in this study, approximately 2/3 had a known diagnosis of heart failure with reduced ejection fraction. From the secondary endpoints and looking at the potassium, blood pressure, syncope, pre-syncope, it was as safe as an initiation of ACE inhibitor in hospital. There was no statistical difference between the adverse outcomes. So let's go back to our case for a second and say the patient has private coverage. So we've written our host of orders at the start, and we're looking at starting them on Entresto 24 or 26 milligrams PO BID. So let's see if they fit the bill. Indications as per the guidelines, so their EF is less than 40%, check, and they have a hospitalization with de novo heart failure, check. But let's make sure that it's okay to start. So important notes, their creatinine is 65, so they have good renal function to start it. Their potassium is 3.3, probably from the diuresis, so we're not going to be too worried about hyperkalemia, which can happen. And they have a good blood pressure and heart rate. Their blood pressure is 108 on 68, and their heart rate's 90. And if we compare that to Pioneer-HF, the median blood pressure is 118 systolic in that trial. Patients were improving, and the median heart rate was in the 80s when transitioned to Entresto. So this seems pretty similar to our patient. We're going to be watching for the adverse effects of hypotension, worsening creatinine, and increasing potassium. So let's change the scenario a little bit. let's say we still have private coverage, but the vital signs are different. The blood pressure is 88 on 58, and the heart rate's 108. Just quickly looking at Pioneer HF data, the median blood pressure was 118 systolic, patients were improving, and the median heart rate was in the 80s when transitioned to Entresto. The other clinical thing that we should be thinking here is that with diuresis, their blood pressure is going down, they may be getting into a low output state, they're obviously still needing a higher heart rate to keep their cardiac output up. They can't augment their stroke volume, so they're relying on their heart rate to keep their cardiac output up. I would even be nervous about starting some beta blockers in this patient and be slightly more worried about starting a potent vasodilator like sacubitril/valsartan. So let's change the scenario again and give the patient pharmacare coverage. Let's put their vital signs back up to 108 on 68 and a heart rate of 90, so they are becoming more compensated. It is very challenging to get someone with pharmacare coverage onto sacubitril/valsartan initiating de novo in hospital. However, pharmacare will cover it in 4 weeks' time provided they leave hospital on the traditional triple therapy. So we would start some type of ACE inhibitor like enalapril 2.5 milligrams PO BID or perindopril 1 milligram PO daily and up-titrate that while in hospital. And then in their discharge summary, or when you see them in your clinic in 4 weeks' time, you can fill out the pharmacare form to transition them on to sacubitril/valsartan in keeping with paradigm HF. So when you see them in 4 weeks' time, you type into Google Nova Scotia pharmacare Entresto, and this will be the first link that pops up. It's an easy fillable form, and provided they're on any dose of the traditional triple therapy, pharmacare has been exceedingly good at approving it. So now with the recent guideline updates, is there anything else we can do to optimize our patients? So this is from the recent CCS Heart Failure Guidelines Update 2021. There's 4 recommendations in there about SGLT2 inhibitors. We're going to focus on 11. So we recommend an SGLT2 inhibitor such as dapagliflozin or empagliflozin be used in patients with heart failure with reduced ejection fraction with or without concomitant type 2 diabetes to improve symptoms and quality of life, to reduce the risk of heart failure hospitalization and cardiovascular mortality. So based on the guidelines, it is reasonable to consider starting an SGLT2 inhibitor, and this can be done in hospital provided the patient is stable and improving. So in the next 2 days, the patient's creatinine is 72, potassium 4.2, their blood pressure has gone up to 112 on 68, and their heart rate's 80s. So it is reasonable to start an SGLT2 inhibitor in hospital if they have private coverage, and you're watching for adverse effects like hypotension, low sugars, and rarely euglycemic DKA. The nice thing about the SGLT2 inhibitors is that you don't need to focus on their electrolytes or creatinine like the other heart failure drugs. This is based on really 2 trials, DAPA-HF and EMPEROR-Reduce. DAPA-HF was the first one to come out and had a number needed to treat of 21 and an absolute risk reduction close to 5. Both DAPA-HF and EMPEROR-Reduce have a reduction in their primary outcome, which is heart failure hospitalizations and cardiovascular death. Dapagliflozin, when you break it down into CV death, it is a reduction based on the confidence interval, whereas empagliflozin seems to be focused mainly on repeat heart failure hospitalizations as opposed to reducing cardiovascular death, as the confidence interval does cross 1. If they don't have private coverage, you're going to be searching for a reason to get them onto empagliflozin, different than the trials with or without diabetes. To get them onto empagliflozin, they're going to need to have diabetes that's uncontrolled on metformin, and they're going to need to have some type of vascular disease as shown in this checklist. So let's go back to the case. I think it's important for us to know that not every patient is going to be initiated on quadruple therapy leaving hospital on a de novo admission. It's going to be a certain type of patient that's improving, has good blood pressure, good kidney function, reasonable potassium, and you think they're going to be able to tolerate it. Keeping in mind that it does take a few half-lives to get medications up to their normal concentration in the blood serum. Now going back to our case, the total of 7 days in hospital, patient has diuresed 7 kilograms and the JVP returns to normal. They come off their oxygen supplementation, the cath shows non-significant coronary disease, medical up titration complete with patient ready to be discharged home with follow-up with the family doctor and the heart function clinic. So if they have private coverage, their discharge medrec is going to look something like this. Bisoprolol 2.5 milligrams PO daily, spironolactone 25 milligrams PO daily, Entresto 24/26 milligrams PO BID, dapagliflozin 10 milligrams PO daily, Lasix 20 milligrams PO daily, metformin 1000 milligrams PO BID, and aspirin 81 milligrams PO daily. If they have pharmacare coverage, it's going to look something like this. The difference being that they're going to be going home on an ACE inhibitor, and you're going to transition them on to sacubitril valsartan in 4 weeks' time. And you found a reason to get them on to empagliflozin because they have uncontrolled diabetes and some type of vascular disease. Thanks again for the opportunity to present. With that, I'd like to open it up to any questions.